Hello and welcome within yet another EAO Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I'm the host of this EAO channel. And tonight we're going to try to answer as many questions as we can about the history of guided bone regeneration. Well, not only the history, also the present and its future. And I'm very honored to tonight be joined live from Sweden by one of the pioneers behind the biological principles of GBR, guided bone regeneration, that is, Christer Dahlin. Christer, good evening.
Thank you, Gerrit, and thank you for having me.
Yes, thank you for joining us live from Sweden. I just, as always, posted in the chat to our viewers, please let us know where you are joining us from. And we already see an audience stretching from the United States to Slovakia to Sweden, like where you are, France, Tel Aviv, Austria, Lebanon, Moldova is joining us. So already connecting with a truly international crowd. And again, let me remind those viewers who are new, but also those who are regular, we are live. Please make use of the opportunity that we are and submit any questions you might have to Professor Christer Dahlin. And if you're thinking, Dahlin, that's a familiar name. I've seen that on many papers. Why is that? Well, let me quickly highlight some highlights of your background, Christer. Okay. You are currently a professor in oral surgery and guided tissue regeneration at the University of Gothenburg in Sweden. But you're also active as a senior consultant in oral and maxillofacial surgery at the NAL Medical Center in Trollhättan, also in Sweden.
Good.
You are a member of many, I'm not going to list them all, but many leading scientific journals, a member of editorial boards of many leading scientific journals in dentistry around the world. And you're currently the president-elect of the Osteology Foundation. But that's all very honorable. But tonight we want to talk about that moment, which is already 30 years ago, I believe, where you were still in your PhD studies. And you you invented the biological principles behind guided bone regeneration. Can you take us back to that time and the thoughts and insights that led you to this fascinating concept?
Thank you, Gerrit. I will be happy to do that. And that brings us back to Gothenburg and the Faculty of Odontology at the late 80s. And at that point of time, I had just graduated from dental school, and I attended a class in periodontology with one of the professors from University of Gothenburg, Sture Nyman. And they had, at that point of time, explored a new principle to re-establish the attachment of teeth that previously has been periodontally affected. And I think maybe we can actually share a slide on that.
Yeah, please. Why don't you pull up your screen while I say hello to some of our international viewers. Zainab joining us from Barcelona, Isabella Roqueto joining us again. Hello. Those of you who are interested in this topic, please also make sure you check out the EAO YouTube channel, where you can find many of the other EAO Just Asked, and one has been with Isabella on this topic as well. We see Henrik from Denmark, Per Otterstad from Norway joining, Declan from Dublin. A very international crowd as well. And again, let me remind you, if anywhere during this talk tonight you have a question, please submit it via the live chat and I will relay it to Christer on your behalf.
Yeah. And I just want to double check with you, Gerrit, that you see my
No, not yet. That's why I kept reading out all these
All right, perfect.
Christer.
I will do a little bit of, I will share.
Share the screen. Yeah, there you go. Now it's happening, and we see the first slide taking us back to the 70s. It shows.
Yeah. Yes, exactly. This was, in short, the principle that was originally developed by the professors Sture Nyman and Torkild Kärring from the University of Aarhus, where they used a barrier, a membrane, as you see here on this slide, to create a secluded space where the tissue could actually reorganize. And it was a significant biological breakthrough. And of course, I was fascinated by this. And as a very young student, I I took the courage to actually call Professor Nyman and said, I'm absolutely, I'm so thrilled about this principle, and I think this must be possible to use also for other applications. And he said, I totally agree with you. Come on over and let's have a chat. And that is actually how it, in a way, how it started. And we did some simple experimental studies. You see here, this is a classical experimental model of a rat mandible, very simple one. You make a defect, what is called a critical size defect. It will not heal spontaneously. And we covered it with barrier membranes, the entrance to this defect, and allowed it to heal. And if I know, Gerrit, you asked me about, one of the moments in your research career. And I would say one of the moments for me, you can see here on the lower right, and that is when we looked at the histology for the first time. And you see these two membranes, which I try to visualize here. And there is a previous defect in here, which was completely filled with new bone. It was truly exciting. And
can you, for those viewers from a younger age, can you take us back to that feeling? Why was it so exciting? What was the entirely novelty here?
The novelty here was that we hadn't added any graft material or anything. We have just created a secluded space by placing this membrane, and the body took care of the healing by itself. It was a very novel way of thinking. We saw healing pretty much as a race between different tissue types, the soft tissue, the bone, where presumably the soft tissue would heal faster. And by placing these membranes, we gave I would say, presumably slower migrating bone tissue a chance to heal unimpededly. That was, I would say, the novelty in this. Mm-hmm. Yeah. Mm-hmm. I would like to jump back again to the era in Gothenburg at this point of time. Because at that point of time, we had an extremely strong periodontal department with Professor Jan Linde, Sture Nyman, Jan Gottlob, many famous persons heavily involved in and actually really setting the landscape for that. But we also had one other thing in Gothenburg at that point of time, and that was the development of dental implants with a group around Professor Brånemark. Mm-hmm. And I worked myself at the Brånemark clinic during these years, and Gothenburg was really the center of the world when it came to developing this treatment. People came flying in from all over the world to train, and we trained, I would say, courses 35 weeks a year, and we had a little bit of vacation, and the rest of the year we were traveling the world to train and teach people. So it was an enormous interest for dental implant treatment. And what soon also became obvious was that in order to place implants, we needed a certain amount of bone tissue, volume, to actually have space to place the implants. And sometimes there was a shortage. And of course, there was a discussion whether this new biological principle could be applicable to create bone around the implant. So the next, and I would say probably the most classical study, is the one that we are using the membrane technique here to actually create new bone around an implant. And I can also, if you think about another moment, I still remember, because this was my first visit to an international congress that actually took place in Arnhem in Netherlands. It was a oral surgery pre-prosthetic congress, and I was giving this scientific presentation, which was, I believe, 8 minutes. I didn't sleep for 3 days before because I was so nervous. But I would like to give credit to my supervisors, also Professor Anders Linde, that really pushed me and said, you need to go to international meetings. That's where you learn science. So I did it, and I also remember the stir in the audience when I actually presented this data and these results, and that's really where, from there, it really took off, I must say.
Exactly.
Yeah.
So this is the start. We are now more than 30 years later, and you are still actively researching the field of bone regeneration, guided regeneration in various shapes and forms.
Yes.
What is it that attaches you to this topic so much? What do you find so fascinating about this field of research?
I think it is a very catchy biological principle, and
why do you say that?
I think it's very special to actually see, because what we are doing is actually that we are guiding the body to heal itself in a way, and I find that very attractive from a biological standpoint, and I have also seen eventually when this became clinically introduced and spread globally, which occurred in the early 90s, I would say around 1992 and onwards. And the fact that we were able a little bit later, when the clinical concept has also been more developed mostly by other groups and so on, that you could actually treat patients with rather severe bone defects with this technique, because the beauty of this technique is that it is much less invasive for the patients. So we had situations where patient usually had to go to general anesthesia, go through large bone grafting procedures and so on. These could be solved in an outpatient setting in local anesthesia in like an hour surgery instead. So it was an enormous benefit also. And that is keeping me interested in this, because we want to refine the concept, make it even more predictable. And it's still around. I looked I looked at some figures, and it is estimated that I think globally we perform somewhere in the range of 20 million dental implant surgeries on a global annual basis, and the GBR, using membranes, the GBR principle is conducted in close to somewhere in the range 5 to 6 million of these surgeries. So it still has a significant impact. Yeah.
It is very significant, and I can imagine that some of our perhaps younger viewers don't even realize the shoulders of the giants they're standing on, right? They come across these huge incidence numbers. They say, well, GBR, yeah, that's what we do all the time as implantologists.
Yes. Yeah.
What can be fascinating by having someone like you who's able to oversee the entire development from this theoretical concept to the clinical application, what are some of the key things that we need to keep in mind when we look at this technique?
I think what we have learned over time is because the clinical concept is of course constantly undergoing developments, and I would say also refinements. And it is a little bit like, doing a recipe in the kitchen. We have learned some occasionally, I would say also the hard way, because we have done mistakes and adjusted the concept and so on. But there are certain steps that you need to take when you do this surgery. And if you do, and I think the important thing is that when you do these different steps, you really need to finalize each step, and then you move to the next step. You finalize that, and then you move like that. It's not like, okay, maybe I can skip this. It's fine. I jump to this one and so on. And there are certain things that we have learned. We have learned that the membrane should be stabilized when we place them in the tissue, not to avoid micro movements. We know that it is beneficial to use some type of bone filling materials underneath these membranes that we're using. We know that it is of great importance how we handle the soft tissue, that there are no tension in the soft tissue when we suture. How we suture, the sutures should be in place for a longer period compared to when we do normal surgery in the oral cavity, because we have a compromised wound that needs that mechanical support a little bit longer and so on. If you see and you attend courses, read the papers, and if you follow all this, you have a good chance to actually be quite successful using GBR.
Exactly. So you say follow the procedures meticulously, don't skip any steps. You mentioned all the things we know, and we also talked about in many outings on the EAO channel as well. So where would you say are the key uncertainties at the moment? Because when we briefly chatted last week, one of the things I wrote down is you said people need to be woken up that this is not set in stone. We are not just there. So where are our major uncertainties and developments that we need to work on?
I think we do have a few uncertainties, and I think we also need to go back a little bit to the history and look at the materials that we were using. And I think I can maybe share my screen again, because I would like to go back to
yeah, go ahead. In the meantime, we see a first few questions coming in. Also, Mitchell Pierce and Benjamin Kojak used the opportunity to send us questions in advance. So I will soon be sending these out to you, Christer. But let's first dive back into time. We see your screen now, so please show.
Perfect. Yes. And I think these are a few of the principles that I mentioned about. We quite early we understood this. You see this membrane that is mechanically stabilized here. We talked about the space making, that we should have something filling up underneath the membrane in order to avoid the collapse and also to stabilize the wound. And as you see here, the material here that we are using, and we will come back to that when we discuss the future. This is a non-resorbable membrane, and this is where the development started. We used a material called EPTFE, expanded polytetrafluoroethylene, which you basically find the similar type of product in your ski jackets and stuff, Gore-Tex, in other words. And you may think, why Gore-Tex in this application? Well, Gore-Tex, or this type of EPTFE material, has actually quite extensive medical history. It has been used and are still being used in open heart surgery if you need to seal like a passage between the heart valves and so on. So we kind of liked that it is a very inert material. to use, and we said, well, if they can use it in the heart, we feel pretty comfortable of using it actually in the mouth as well. It's a beautiful material when it comes to tissue response. The problem is that it is a little bit technique sensitive. And what we have been struggling with is that this soft tissue coverage of this material is a little bit difficult. So you may face problems with that the material becomes exposed during healing, and that has been a major issue. So if you summarize this type of material, historically it provides an excellent healing outcome, but it is somewhat technique sensitive, and that eventually led to a development of a next generation of membranes that you see in the schematic drawing of here, which is the resorbable membranes, which are, I would say, the workhorse today. They are, in a way, they are user-friendly, more forgiving. And I would say that we are using it in the majority of the surgeries that we are conducting today. But they are, if you have more severe, more advanced defects, they tend, because they resorb, they also lose their configuration, and for that reason, for more advanced surgery, we still need the other type of membranes, the non-resorbable membranes. So we kind of are working with both types. There are slightly different indications or applications for them. Yeah.
And you say, when I ask you what are the key uncertainties and things we need to work on moving forward, you say it's in the area of the membranes.
Yes.
And in what direction do you expect this to go?
I think we are looking at some exciting developments within the and that's what I'm basically doing. I try to look a little bit in the crystal ball and see if there are ways where we can, for more tricky applications, if we can make these membrane materials, mostly the non-resorbable membranes, more, I would say, more predictable, and it's also maybe more forgiving in the surgical procedure. And so that's an area where we are working a lot. And if you want me to share, I can show you a little bit the ongoing trends, so to speak, in that area. I would be happy to. Yeah.
Well, let's park that and leave that as a cliffhanger for a little later during our Just Ask. Let's go to a few first questions first.
Absolutely.
First one is interesting. It's coming from Isabella Rocchietta, and it's slightly off topic, but very on topic as well, because you were sharing about how you went to Arnhem to that first conference, how nervous you were. Actually, before that, I already heard a valuable lesson to everyone joining tonight. The fact that you just reached out to the professor to ask, to tell you and share with you how you could start to work and apply those principles. She's asking, if you had to give out the biggest advice to a young researcher or clinician today on how to write or share his or her story, what would that be? Because obviously the sharing of the story, the telling of the story is a big part of why you have become such a pioneer in the field.
Yeah, I think that's a very good question that we can talk about almost for the whole night. I think it is important, of course, to reach out to experienced professors and don't hesitate to do that. Sometimes you have a huge respect for them, but it's usually highly appreciated if you come and do that. The next thing I really would like to give as an advice is actually to do what I did. Don't be afraid to go to international meetings early in your research career. It's something that we, for instance, with my involvement in the Osteology Foundation, we have a lot of activities that are reaching out to young researchers, because we have seen that this is so beneficial. You learn a lot, you get good feedback, and you also start at an early age to create a nice network. And it is for you yourself, it is a booster for yourself to actually manage and do this. So don't be afraid. You will not sleep, as I did not either the first time you do it, but it has helped me a lot. And the next thing I would like to say, and that is also spend a lot of time and also maybe take help to develop your presentations, whether it is an oral presentation or if it is that you have a poster or something, because you may have spent a year or two in conducting the research, and you can basically ruin the outcome of that if you do a sloppy presentation. So spend a lot of time of that and rehearsing. I do that sometimes, especially for these short scientific reports, which are like 7-8 minutes. They are usually more tricky than speaking for an hour in front of an audience.
We have today. We can
go freely and so on. so we really rehearse this with the PhD students. Sometimes they almost start throwing things on me, because it's a little bit like my Fair Lady and Professor Higgins. Again, do it again. But you should be well prepared, because that builds up your confidence when you go there. You should be well prepared, at least. Yeah, of course, you develop some
advice.
Yeah.
No, I was going to say, I think this is good advice for anyone at any stage in their career, right? Never underestimate the
I have learned from the masters, because I've seen famous professors like Jan Linde and so on, and see them actually rehearsing lectures for dental students. They do the same meticulous preparation for a lecture for dental students as they do in front of an audience of 3,000 people. And that was, for me, an eye-opener. That's okay. This is the work that they put down before they present. And
Beautiful.
I think we can learn from that.
Exactly. Beautiful advice. Thanks, Isabella, for taking that course as well. I see Tali Shakachi also submitting a question. But first, I would like to go to a question that was submitted before we started. Always at these EAO Just Asks, we always also ask our audience to send in any questions or cases beforehand. And Mitchell Pierce, we already saw him sitting ready early live from New Orleans in the United States. Mitchell, good afternoon to you. Obviously, there's a lot of questions involved around materials and innovations in that area. And his question is related to that. He says, could you please comment on biphasic CASO4 as a GBR grafting option? And I think we should first briefly explain what biphasic CASO4 is to our broader audience.
Yes. Biphasic, it stands for biphasic calcium phosphate. Which is a synthetic graft material. And basically what you do with this type of graft material is that you you try to mimic as much as possible the chemical structure of the original bone. That is a little bit the rationale behind that. The biphasic calcium phosphate is it's an interesting group of materials, because what you can do here is that you can actually add more than one, I would say, type of graft material within the same material. I think, yeah, maybe we could. Now I really would like to share.
Yeah, sure. You've prepared some beautiful imagery to actually guide us through.
Now I think
please go ahead.
It helps the discussion a little bit here. So I think I would like to share this.
In the meantime, let me re-invite all our viewers, perhaps also those who joined later, to follow up your first advice to any young researchers or to anyone, that you really should reach out to those respected professors in the field. As Christer just mentioned, they really appreciate that. So please use the opportunity of the fact that we are live tonight. And even if you're watching this in recording, please submit your questions right below in the comments, so the EAO Communication Committee can use those as kind of a source of inspiration for future topics of this EAO just asked. Christer, tell us.
Thank you. I think these slides a little bit illustrate, I will say, the holy grail of creating bone substitute materials, because what we would like to achieve with a bone substitute material is ideally the material should be degraded and replaced by the patient's own bone, as you see here to the right. And it's a question of finding the balance, because if you have a bone substitute, where you see here on the left, that actually degrades very, very quickly, the newly formed bone doesn't match up, and you have a gap in the healing process. On the other hand, if you have a bone substitute material that does not degrade at all, it is in many situations also beneficial, but it also steals, I would say, some available space for bone formation. I can show you here, because this is actually from a study that we have done some years ago, where you can play with this biphasic calcium phosphates with different, we talked about that, you can combine different types of materials and different ratio, and you can create different effects in the tissue. One concern is that if you add too much of a material that resorbs too quickly, as you see here, it also creates inflammation in the bone. And that, to a certain extent, inflammation is good, but I think too much inflammation in conjunction with membranes and so on could be a concern. So this is something that we are looking into when we are looking at, reported complications and so on. If it's not so much due to the membranes that we're using, that instead it's actually maybe the filling material that cause irritations. So we have seen that when we have using more slow or even no non-resorbing materials like bovine bone and so on, we see less of these types of reaction. But this is an ongoing process, looking again a little bit on the holy grail of bone substitute materials.
Exactly. And let's to finish that question also, let's understand, what would you say are the key drivers to look for these synthetic alternatives to whether it's human allograft or
exactly,
xenograft
or
type of
xenograft? Yes. I think the driving force behind the synthetically created bone graft materials, well, there are several. Since most of them have like a biologic origin, we do have and derives from different various types of animals, for instance, bovine and so on. you are a little bit in the hands of the quality and the health of the animal when it comes to the quality of the product, as well as I think one of the driving forces has also been that we, in several parts of the world, there are actually some religious issues of using different types of material. But I would say for me, the main driving force with the synthetic materials is that the production process of these materials is very controlled today. And we can also do so much more with our materials. We can play with them, with the structure, with the surface chemistry and so on, which we couldn't if we go back like 20-25 years. So I think mostly the production today and the fact that you can standardize that is the driving force today.
Exactly. And to finish off Mitchell's questions, if you comment on biphasic K4 as a grafting option, how far are we? Is this close to clinical reality? Is there still too many unknowns that need to be researched? What is your view?
I think some of these materials are to a certain extent commercially available. I think they can be. There are still room for some improvements. In that sense, yes.
Exactly, still room for improvement, working on that. We started briefly to talk about the membranes. You explained where we're coming from, where you say the driving force is to make it more forgiving, less technique sensitive, so it's more available to all. I think Tali Shakarchi's question is related to that. She writes, would you consider the cross-linked collagen membranes as an intermediate material, so between resorbable and non-resorbable ones, due to its stability for a longer time?
Okay. Thank you for that question. It's a good one, and we, as I think many of our listeners are aware of, there are commercially available membranes, biologically degradable, which are cross-linked. If you cross-link collagen, what you do is that you, I would say, slow down the resorption rate, how fast the material degrades. So you will keep an intact barrier for a longer period of time. So I totally agree that it's kind of an intermediate type of membrane because a non-cross-linked collagen membrane, which are, I would say, dominating the market right now, they degrade somewhat faster. I would say the drawbacks, if you look in the literature and experimentally with the cross-linked membranes, are that they are not so inert in the tissue. They create a little bit more tissue reaction, so it's less forgiving than the non-cross-linked collagen membranes. But you can definitely be successful. But then those, the recipe in the kitchen, the different steps that you need to take, they come into play more actively if you use this type of material.
Which means you need to be much more precise, and the chance for errors and thus complications is larger.
It's a little bit larger, yes. Yeah.
Exactly. Nice. Well, the title of this session is called GBR, the history, the present, and the future. And I see by the type of questions that we start to receive that people are slowly wondering about what your view on the future is. So let me read out Christina's Ivancheva's question. She's wondering, can you tell us something about the biological 3D printing of hard and soft tissues and how that could be applicable in guided bone regeneration procedures?
Yeah, interesting area, because we certainly are moving into a field where the technology in combination with the biology gives us opportunities that are absolutely fascinating. And you know that today we can almost 3D print organs and so on, and for sure we can 3D print scaffolds and membranes as well. And I know, when we have also looked into this, that there are groups that are exploring this possibility. And I would say there is no doubt that I think this is part of the future. There is always a balance, because if you're going to do 3D printing of various structure, it means that you need to collect data. You need to have a lot of software. The patient needs to undergo a CBCT scan or something, which are eventually converted into software programs, and you design. That is, we definitely have the know-how how to do this. The question is, in the clinical situation, how rational that is.
Yeah, where would it make sense? Would you like print a combination of graft and membrane all at once and just insert it? Would it be something like that?
You could probably do that. And I think in some cases, we will probably do that in the future. If we already beforehand know that this is a significant big bone defect and we need to treat this, then you can plan your surgery by doing that. But I think it will not replace the fact that when you are doing, I would say, more minor surgery procedures, and you suddenly discovered in the middle of the surgery that, okay, I really need to develop some bone here or regenerate some bone, then that technique is less ideally suited. Then I think the good old-fashioned GBR is a better option. Exactly. So I think it's a balance. We have the know-how, we have the knowledge, we have the software, the hardware to do this. The question is, will it take us forward, or is it too complex to introduce and incorporate in our clinical situation? I think it's more that question. Is it simply too costly and things like that? Yeah. But biologically, we are almost there, I would say.
Yeah. So this is a balance of between what's possible technologically and what's necessary and makes sense in the clinic, right?
Yes.
So we'll need to find that out. Yeah. Interesting. Thank you very much for your question, Christina. I see that we get some more questions more tailored to the recipes that you mentioned, Christer. So let's see if we can tackle a few. Angelo Menucci is writing, when we were talking about the membranes, how long do you consider to be necessary a membrane to maintain the defect secluded to assure/promote/help the bone to heal? And this is quite related to a question from, let's take this one first. Let me not start grouping questions.
It is a very good question. And to a certain extent, the answer is it is a little bit empirical in that we have learned, but I think a good rule of thumb that you can have when you also discuss with patients and so on, because that we have studied, and that is that bone heals and remodels with a pretty constant rate, and that is approximately 1 millimeter per month. Which means that you can estimate, I think in most of the most situations, it is we are talking about relatively long healing periods. It's usually in the range of 6 to 7 months, and we also have recent data that I would say another lesson is time is on our side. These are long treatments. If you extend the healing period, I think the outcome will be even better and more stable. We are a little bit, why people have had some failures is that I think you have not waited enough time. It takes a long time for the healing to occur.
Exactly. Yeah. Exactly. So you say in the end it's almost a calculation. You can calculate how much new bone you need, the height, the length, the width, and you can just use that. Well, and, as I said,
yeah, please
go ahead.
Yeah, no, so it depends a little bit on the defect. Sometimes we need to build the bone from a flat surface and moving upwards, for instance. Then you can basically calculate how many millimeters am I going to do and do that. In another situation, it can be it could be a socket, a hole where the tooth has been sitting in the jawbone, but then that defect could be like 7 millimeters across. But on the other hand, that then the bone
from all sides, right?
From all sides, so it will go faster. But somewhere in the range of, in the back of your head, think about this 1 millimeter per month. And it's also something which it's an extremely good communicator to the patients, because of course they want the treatment to be finished and so on.
Exactly. They want to be able to explain to their family, why are you not having your implants yet?
Exactly.
Well, 1 millimeter a month.
1 millimeter per month. Yes.
That makes sense. Yeah. Well, and as I said, it's slightly related to David Gonzalez. Here he is with his question. He says, hello, Professor. We saw you earlier, David. You guys know each other very well. Well, it's slightly related to the same timing question, but now he's bringing in the material choice as well. He says, in your opinion, what is the optimum healing period? And again, we already know it depends on the case, of a vertical 3D guided bone regeneration using autogenous bone only and the PTFE GBR. And then he says, what about 1 year, which is my favorite healing period?
I totally agree with David that I think what we have seen also, I have seen David's material, so I know that it seems, because historically I would say we have been looking at 6 to 7 months of healing, and the bone is there, but it seems like the bone has not really quite finished remodeling yet. So an increase in healing period, moving away from 7, more looking at 1 year than 6 to 7 months, is something that is actually a little bit part of the future, I think. I think there are more and more evidence that we need to extend the healing periods a little bit. Yeah,
exactly. That's why you say time is on our side.
It goes against all the things that it should be quick fix and everything, but maybe we have been a little bit too quick, and the biology has really not caught up with us. So
maybe to make the warning complete, what is the biggest risk of failure or complication? Is that just primary stability, or are there other risks if you move in too early?
I think if you move in too early, the bone is not fully matured yet, so you will face problems with stability of the dental implants. And I would say also when you put these implants into function, that you have a remodeling, and you basically will lose some of the bone that you have created.
Exactly. Well, very clear. Thank you. Now, Amit B or Bai, I'm not sure how to pronounce, notices something that crossed my mind as well when we started to talk about the synthetic bone. He or she writes, initial principles of GBR were how to give the site a chance to heal itself. You showed us the rat mandala with the gap which healed itself. But since industry started to come up with materials that attempt to take over the healing from the body by attempting to mimic it instead of promoting natural healing. What is your take on this aspect? And I'm hinting about autogenous versus non-autogenous, she says.
Yeah, very good point. I think just to jump back again a little bit in the history, when we started and we explored this biological principle, and we thought more or less that now we're going to change the world here with this, we were, I would say, purists, because and we were only using the membranes and creating like a secluded space underneath the membrane, because we thought the membranes will take care of everything. We don't need any bone grafts whatsoever, and so on. But we saw that we were not that 100% predictable when we were purist or fanatic, whatever you like. And I think what is the problem here is that underneath this membrane in this secluded space, we need some type of tissue to form. And what does normally form in a wound? Well, we will have a coagulum of the blood, and the coagulum is because the bone needs something to grow into, like a scaffold and so on. But the coagulum is a very fragile structure, so it tends to collapse because of the pressure and so on. So I would say one of the major key issues of the bone graft material is to create this scaffold and also to stabilize, so the bone has something to grow into. And we became so much more predictable, so that eventually became the standard of care to use something. Exactly. And I would say autogenous bone graft in many ways is the most biological materials, of course. I think the development of synthetic or xenograft and so on is because it's so user-friendly. You don't need to go and harvest the bone, you can actually have it. So, and the outcome has been, I would say, so good and predictable. So it's also the clinical situation that are driving this development.
Exactly. And so your take is, understand the history. First, we started to add the grafts, and now we actually see, well, if we don't have to graft from the human, we don't have the comorbidities of the graft site, and that is just an improvement towards the patient's experience.
Yeah. But I think also what we start to see, that if you have really more advanced, difficult cases, it seems like the impact of the patient's own bone, the autogenous bone, is, I would say, is probably the best choice. So it makes the surgery a little bit more demanding because you need to collect some bone. But I would say it's worth it.
Exactly, exactly. Well, that brings us to a few questions that I see, which are related to what is your take on doing A, B, or C? Let me throw you a few of those. One of them is from Benjamin Kojak, who also submitted his question before we started. And he is from America, which is relevant in this context, because he starts about WNT3A. And we both previously had to look that up before we started. But this is in the area of growth factors. He writes, becoming a big thing, entering into the clinical testing arena after many years of in vitro and preclinical studies. Here's the ball. What is your opinion in its use of guided bone regeneration in comparison with other molecules, such as BMPs, bone morphogenetic proteins?
Yeah, even if I'm not an expert exactly on that specific substance, I'm aware of this research that is ongoing and is moving towards clinical applications and indications. But if we look at the use of growth factors in general in conjunction with GBR, there are it has been explored already. I think we did some studies in 2000, and there are also other groups, as in particular of using bone morphogenetic protein, which is an extremely well described growth factor, and so on. The problem with these materials from a biological standpoint is that you need a certain dose, a certain concentration in the tissue to have an optimal effect. And it is very difficult to control that dose in a healing environment. That is one example. I just quickly would like to comment on another growth factor, very well known for bone formation. Transforming growth factor beta is also one that was in the early days commercially available. It's very potent for bone formation in one concentration, but if you increase the dose, it suddenly switched the effect 180 degrees, and it starts to stimulate bone resorption again. So the problems with all these materials has been to solve a predictable, I would say, drug delivery to the wound healing area. I know that there are these types of biologics that has been developed and I think are showing good results. In the US, we have unfortunately limited experience in Scandinavia and also I would say in Europe, and that is for regulatory reasons. It's so it has not really started to fly in our part on the globe. No.
Exactly. And if I understand you correctly, you say there's definitely seems to be some potency from a biological perspective, yet be aware that there's challenges in relation to dosing and location and specificity of that. So quickly adding the question of per-autostat to that. So how about vitamin D? Does that play a role in the bone healing of guided bone regeneration?
It does in regular bone healing, so I would assume that it does, but I cannot recall that I have seen any studies specifically shooting on that topic. No.
No. And would you expect that there would be similar problems to the dosing there, or would that be what would
I would say
yes.
Be? Yes, probably. It would be,
exactly.
But it's definitely worth exploring. Absolutely.
Exactly. Well, thanks, Per. If you have anything to share with us on that, please let us know via the chat. Another question from Claudio Soldini. He writes, so what is your opinion? You see where we are now, They're just pitching your thing. So what is your opinion on this one? What is your opinion about the use of guided bone regeneration or the use in guided bone regeneration, I should say, of quote-unquote dense membrane intentionally exposed without soft tissue covering? Before you answer that, please explain to our broader audience why you would do that and what the expected benefit of that would be.
And now we tend to be more, I would say, material specific, and we are also touching a little bit, I would say, the future, the research, where we are heading, because this is an area which I'm currently exploring quite a lot.
Let me explain to our viewers who haven't Googled you. You are currently the project leader of the Biomembrane Research Group, a multidisciplinary group in Sweden, government funded, who is searching for biomaterials in this field, correct?
Yeah.
So what can you share from that perspective?
I think I would like to pull up a slide in order to illustrate that.
Please do that. In the meantime, I'm going to remind our audience that intentionally we have about 10 to maximum 15 minutes left on this EAO Just Ask with Christer Dahlin, one of the pioneers in guided bone regeneration. So please make use of the fact that you are here right now, that we are live, and please submit your questions to the live chat here on YouTube. In the meantime, we are getting your screen back up to dive into Claudio Soldini's question.
Yes.
And the future of the biomembranes.
I think I would like to show here a little bit what we think is a little bit the future and where we are today. Because if we look on the left slide, we see, I would say, the traditional type of ePTFE membrane, both the expanded as well as another version, which I will come back to shortly, which we call the dense PTFE membrane. But as you see, they are more or less comprising of one structure. And this is something that we have started to question a little bit in our research group, because if you look at the wound healing system here, we have the underlying bone, we have a defect in the bone, and then we have the soft tissue on top of this membrane. This is the wound healing situation that we have. And the fact is that soft tissue and the bone are two tissue types that have actually very different specific needs during wound healing. So what we are currently doing here is that actually we are working on a new generation of membranes, which has like a dual configuration where we optimize the structure of the membrane facing the soft tissue, and we optimize the membrane towards the bone defect. This is something that you can also use. I will jump to another slide further down here. Coming back to the differences between an expanded and a dense membrane, if we look at these, now we nerd a little bit here and look in electron microscopy, but it's very illustrative here. An expanded PTFE membrane is, I would say, it has a lot of fibers which are oriented in a three-dimensional pattern, so to speak, while a dense PTFE is more of a homogeneous type of material. If you do some cell culture studies here, there are some human gingival fibroblasts that we have seeded on these different types of membranes. We do see that on an expanded PTFE membrane, what you see here, which looks almost like a spider here, this is a fibroblast cell, which are attached to the surface. And this is all typical signs of a very healthy fibroblast. While they have this more rounded structure when they are facing a dense PTFE surface. Basically what we can say, they have difficulties to attach to that surface. It's too dense. So there are differences in the biological response to expanded versus dense material. Historically, the expanded PTFE with its network and so on was also associated with that bacteria could grow into that if you intentionally left it exposed, as the question addressed here, and that created difficulties with infections and so on. And that, I think, also led to the development of the dense PTFE material. What is also new with I would say, the new generation of ePTFE, this network type of membrane, is that you can make this material 100% occlusive for bacteria, even if it's an ePTFE membrane. So this is actually, it's a good question, because this is something that we are currently looking at quite a lot. I've seen several reports on this. We simply would like to do this, make this membrane more forgiving, so you can intentionally use it and leave it open, but also in the this is the most feared complication when you work with this type of membrane, is that it becomes exposed. And by creating a surface that kind of repels bacteria as well, that will increase the predictability. I would just say one more sentence about this, because when it comes to biofilm formation, bacteria on top of a membrane, bacteria like to grow in clusters. That's the way they are brought up, so to speak.
What are you looking for?
I'm looking for a slide. One final. Yeah.
Just the final image. Yeah. Because let me re-summarize. You say so in the future of these membranes, we are looking for solutions and materials innovations that these membranes can be more forgiving, specifically because now, as you mentioned earlier in the talk, it's so technique sensitive. It's very dependent on the quality of the surgery, mainly on the soft tissue currently. And if you could be more forgiving in that area, that could be the biggest opportunity to make this more available.
And just to illustrate what I talked about, these are biofilm or bacteria that are forming on a dense material, and you see they like to form in a cluster, while if you have a surface that are with a lot of fibers that are running in different directions, bacteria doesn't like to be forced out along certain lines. So you can actually decrease the amount of bacteria by altering the surface of the membrane as well. So this is also part of, I would say, the future ongoing research.
Exactly, and that would then hopefully in the future make it much more applicable to even more colleagues in the field to apply these type of techniques to even more and more patients. That's the aim. Beautiful. Well, thanks. You were a bit all over the place, but I think, Claudio, you have the key point here, and it's very exciting research that you are working on. Now, I would like to refer to when we chatted last week, we talked about your current background. When I introduced you, I explained you're both a professor at the university, but also with one leg in the clinic. And you refer to a quote, it's kind of like the Blues Brothers. You have to put the band together.
Yes.
As a closing point in this EAO, just ask, why is it so important to bring the band together? What do you mean with that quote?
What I mean with that is that, you know, when I started to do research, which, as we discussed and we figured out was a while ago, many years ago, we had a very limited number of surgical or research techniques to study events around healing. We were mostly relying on doing histology and looking in the microscope and so on. So in a way, that was a type of research that you could be the lone wolf, so to speak, in the lab doing all that part of yourself. But today we have so many new sophisticated techniques. We are working, of course, we're still working with histology and doing measurements, but we also we're using micro CT, we are using molecular techniques to go in the hunt for mechanism. If we're looking for mechanism, molecular techniques to see how cells are up or down regulated is the way you do it. If you really want to understand biological principles, and you need to play the whole piano here, and using all these techniques, and each technique by themselves are so complex. So you have to be modest and say, I cannot understand all the details in each and every part. So you need to bring in a group where you have experts in the respective field. And that's what I mean with putting the band together. You may have the helicopter view of an understanding, but you need people helping you out with the details. That's putting the band together in the Blues Brothers.
So that's a call to action to all our viewers, either still live with us or in recording, that we need to further work on this topic. It's not set in stone at all. We can expect specifically in the field of either the innovative membranes and or the innovative graft materials, synthetic graft materials. There's a lot to be expected and to come in the future of guided bone regeneration. To start to wrap up, if after spending 70 minutes with us together, Christer, if there's one important thing that you would like to underline to our audience tonight, what is the key thing that you would like people to walk away from this session with?
I think I would like to really encourage people, if you are working with dental implant treatment and you see the need to work with guided bone regeneration, I really would I would welcome you into this very special field. Selecting your cases carefully, starting with easy indication, and build your knowledge, and then you develop your ladder by yourself, and you will be part of, I would say, a very fascinating technique, and it's very easy to get addicted to when you have had some successful results. You also get interested in the biology, of course. So
exactly.
A
fascinating concept and technique that's been able to fascinate you for over 30 years, and you're still doing that. Also spending your Monday evenings with us here on the EAO YouTube channel. Let me, on behalf of all our viewers, and we already start to see some big thank yous in the live chat here. We will read them together after we stop the live broadcast. Let me, on behalf of the entire audience, thank you for your precious time tonight. On behalf of the EAO and of course of the communication committee specifically, who editorially puts together and searches for experts. And let me invite all our audience members who are still watching this to a few things. First of all, in heart of the tips that you shared with us earlier, Christer, first of all, reach out to all the professors like Christer Dahlin if you have a question or an idea. It's valued. Make sure you put yourself on these international stages like the EAO provides. And of course, we are in a special time currently in 2021. We have to see whether congresses go physical or online, but at some point the meetings will come back. And please join us in those meetings, whether it's EAO or any of the other associations, scientific associations. Please come join us. But in the meantime, make sure you stay and come back to our EAO YouTube channel. It's where you're watching right now. If you haven't done so, make sure you hit that subscribe button so you'll be the first to know when a new video is published. You will also be able pretty soon, when we stop the live broadcast, to reshare this video with anyone you can think of who might find this interesting. It could be either this video or any of the other 14 EAO Just Ask sessions that we have lined up there already. And as you know by now, normally it's every first Monday of the month. However, in April, that first Monday is a national holiday here in the Netherlands. We have an extended Easter. So next month we're back on Monday, April the 12th. Please mark your diary for another EAO Just Ask. But for now, Professor Christer Dahlin, thank you very much for being with us tonight.
Thank you so much, and thank you everyone for listening. It's been a pleasure.
Exactly. We're looking forward to see you back next time.
Thank you.